training session or talk going on. And today we are going to cover very important and practical topic, traumatic brain injury. There are two good. Okay. There are two talks. The first talk is on managing a traumatic brain injury from the doctor's intensivist perspective. This is going to be done by Dr. Subba Reddy. Dr. Subba Reddy is the senior consultant in MDCCU at Hyderabad Apollo. He's a qualified intensivist. He has done various degrees, PDCC, IDCCM, IFCCM, and European Diploma in Critical Care. And he has more than 15 years of experience in critical care. He is also medical director of Apoka's Rehabilitation Center, and he is also the ISCCM Hyderabad branch chairman. Okay, so he is going to talk on the intensivist perspective of managing a traumatic brain injury in the next 30 minutes around. Then after the talk, we will have around 10 to 15 minutes of Q&A session. There is also a chat box. If the delegates can look at whatever doubts they have, they can put it in the chat box. We will try to answer it at the end of the first talk. Okay. Dr. Subba Reddy, welcome. And the next 30 minutes is yours. Please go ahead with your talk on TBI management. Welcome.
Thank you, Dr. Sendil, for that nice introduction about Apollo Center of Excellence in Critical Care. And I congratulate Apollo Center of Excellence in Critical Care people and Apollo Knowledge Series people for having these wonderful webinars, because we always believe nurses are the backbone for the ICU. If we don't train nurses, if there's no critical care nursing nurses training program, then there's no point training only intensivists, and will not be that good. So we and then Rita will be talking about the traumatic brain injury nursing perspective, and I'll be talking about the intensivist perspective. And traumatic brain injury now is becoming a pandemic because of urbanization, and then we see a lot of motor vehicle accidents. And if you're working in any neurointensive care unit, we see a lot of patients with traumatic brain injury. And not only the neurointensive care, even when you are working in a small center, we get these patients to emergency, and then we have to provide initial care. And then if there are no facilities, then we have to shift to higher center. And we should not neglect whether it is mild traumatic brain injury, moderate traumatic brain injury, or severe traumatic brain injury. Even mild traumatic brain injury also we should not neglect, because sometimes these patients will have significant neurological deficits if we don't manage properly. We all know the primary brain injury and the secondary brain injury. Secondary brain injury is more dangerous than the primary brain injury. So the good intensive care, good emergency care initially, and good after that, good intensive care will really help to improve the outcomes. So I'll be talking about the intensive care perspective, and what are the new guidelines, and what is the role of the decompressive cranictomy, what is the recent evidence for it, and all. Coming to the definition of traumatic brain injury, it is defined as any disruption to the normal function of the brain that can be caused either by a bump, blow, or jolt. Any mechanical force resulting in injury to the head will lead to traumatic brain injury. And then if there is any period of loss of or decreased level of consciousness, any loss of memory of events immediately before or after the injury, or any neurological deficit, and then any alteration in mental state at the time of injury, called as traumatic brain injury according to the definition. If you look at the epidemiology, Ms. Ravita is going to talk about the Indian census and what is the incidence of traumatic brain injury in India. Overall, we see 69 million individuals estimated each year suffering with traumatic brain injury, and this is most common in Southeast Asian and Western Pacific region because of more urbanization and more motor vehicle accidents in these areas. So even in US, it is estimated that 29 million people injury. So coming to the classification, we all know about the Glasgow Coma scale for the neurological assessment of a patient with traumatic brain injury. I'm not going in detail because all of us know Glasgow Coma scale, and we monitor these patients in ICU every hour. We look at the GCS, and then any drop in GCS, then we think about doing imaging or further investigation, like CT or further investigations. And another classification is Marshall scale. This is based on the CT. We have diffuse axonal injury, grade 1, grade 2, grade 3, and up to grade 6 based on the CT, based on CT findings we define. And if there are no any intracranial pathologies, then we call it as, we classified it as diffuse axonal injury grade 1. And then if there is any high mixed density lesion more than 25 ml, which is not surgically evacuated, we consider it as grade 6. So whatever classification we use, we have three different, you have to classify the severity of the traumatic brain injury. We have to classify whether it is mild, whether it is moderate, or whether it is severe. For that, we have to look at the CT, we have to look at the structure in the imaging, and sometimes it may be a severe traumatic brain injury according to your GCS, but if you look at the CT may look normal. So it is classified based on GCS. If the GCS is 13 to 15, it is mild, 9 to 12 is moderate, 3 to 8 is severe. And then based on post-traumatic amnesia, and if it is for 1 day, we consider it as mild. If it is 1 to 7 days, then it is moderate. If this post-traumatic amnesia more than 7 days, then it is severe head injury. And based on the loss of consciousness, if it is less than 30 minutes, then it is mild. If it is 30 minutes to 1 day, it is moderate. More than 1 day, it is severe. And based on the abbreviated injuries severity score that we commonly use in emergencies, and if it is 1 to 2, it is mild. If it is 3, it is moderate. If it is 4 to 6, it is severe. So again, the traumatic brain injury, it may be due to the primary injury or it may be due to secondary injury. Primary injury is basically basically because of the physical damage to the parenchyma. Secondary injury because of cerebral edema, hematomas, hydrocephalus, intracranial or seizures can cause secondary brain injury. So coming to the cerebral edema, maybe because of hematoma, initial hematoma, later we see cerebral edema. And then if there is any intraventricular hemorrhage, then we see hydrocephalus, and any metabolic derangement can cause secondary injury. So what are the potential systemic complications associated with serious traumatic brain injury? So any fever can worsen traumatic brain injury. Any arrhythmia, bradycardia, tachycardia, any hypotension, apnea, or any aspiration pneumonia, any ventilator-associated pneumonia, or any gastric erosions, ileus, and any perforation or any dehydration leading to acute renal failure can worsen traumatic brain injury. Anemia, leukocyte metabolic derangement like hyponatremia, hypoglycemia, hypokalemia can cause more secondary brain injury and worsen the traumatic brain injury patients. So coagulopathy is very common. Coagulation disorder is a common problem after traumatic brain injury, and coagulation disorder could result from traumatic brain injury and it can cause secondary brain injury. So we all know the CRASH trial because the prevalence of coagulopathy is very high in TBI. It is around 32%, and it is up to 60% in severe traumatic brain injury. And that's why the CRASH-3 trial, when they use a tranexamic acid, is a procoagulant drug, there is decrease in the mortality. And this the CRASH-3 trial, the tranexamic acid for the treatment of significant traumatic brain injury. In this, they found the mortality benefit when they use tranexamic acid within 8 hours of brain injury. So how to, the main goal of your traumatic brain injury treatment is prevention of secondary brain injury. Then you will have better outcome. If the patient has secondary brain injury, then we'll have poor outcome. So primarily, we have to prevent hypotension, hypoxia, hypothermia, and hyper or hypoglycemia, and vomiting, or any seizures, hypertension, hypercarbia, or if there is any impaired cerebral venous drainage. Sometimes if the position is not good, if the neck is flexed, or if you're using internal jugular veins lines, then the cerebral venous drainage will be impaired and the secondary brain injury. will happen in those patients. Coming to the critical care management, how do you address all these problems? So what are the treatment modalities we have? We have cerebral spinal CSF fluid drainage, and we have hyperosmolar therapy. We have ventilation therapies. We use anesthetics, analgesics, and sedatives. We use steroids, and we look at the role of steroids in traumatic brain injury. What is the evidence? And seizure prophylaxis, nutrition, decompressive craniotomy, and like we talk about decompressive craniotomy, and we look into the evidence. Is there any role of prophylactic hypothermia, and is there any role for infection prophylaxis, and what kind of DVT prophylaxis we need to give? We go through this Brain Trauma Foundation guidelines. So these guidelines, basically they're classified as class 1 if there is a good quality randomized trial, class 2 if there's a moderate quality RCT, class 3 is the low quality RCTs, and moderate to low quality cohort or case control studies. And coming to the level of recommendation, if there is high quality evidence, we say level 1 recommendation. If there's a moderate quality evidence, then we say level A recommendation. If there's a low quality evidence, we say level B and level 3 evidence. So the cerebrospinal fluid drainage is very, very important when you are managing traumatic brain injury. The EVD drainage is controversial. Like you have to decide whether we have to go for intermittent drainage or we have to go for EVD. So we know whenever it is a severe head injury, and then when we drain CSF, the ICP will come down. So, like we do intermittently in some centers, and then we do continuously in some centers. So it is like in the guidelines, they said, and according to the evidence, continuous drainage is preferred than the intermittent drainage. So, but we need to look at the infection and what type of ICP monitor we are using. We are using intraventricular catheters or intraparenchymal catheters, we should remember. Coming to the evidence, it is level 3 evidence. The drainage of CSF may be considered to lower the ICP burden more effectively than intermittent use therapy. Whether we use like 3% saline. So like our goal is to decrease the ICP. And when you're using hypertonic saline, we have to be very, very careful about central pontine melanosis. And role of diuretics, there is no much evidence in traumatic brain injury. Coming to the recommendations for hyperosmolar therapy, mannitol is effective. This is according to the 3rd edition guidelines. Mannitol is effective for control of raised ICP at the doses of 0.25 to 1 gram kg per body weight. And we have to avoid arterial hypotension and strict mannitol usage prior to the ICP monitoring. If there is any signs of transtentorial herniation or any progressive neurological deterioration, we use mannitol, but we should be very, very careful when you're using mannitol in a patient with extradural hematoma. There may be expansion of the extradural hematoma. And in the 4th edition guidelines, there is no recommendation mannitol. They just concluded saying that we needed further studies, but whether you use mannitol or hypertonic saline, if you have good ICP monitoring, if you monitor ICP, if it is less than 20, then we need not go for the hyperosmolar therapies. If it is more than 20 millimeters of mercury, then we have to go for hyperosmolar therapies. Coming to ventilatory modalities, so we need definitive airway protection because the risk of pulmonary aspiration, compromised respiratory drive, whenever there is a compromised respiratory drive function, whenever there is transient hyperventilation, we need definitive airway, and then we have to control the ventilation. So the goal of our ventilation in TBI patients, we have to maintain normal ventilation, normal PaCO2, and low PaCO2 will decrease cerebral blood flow and causes cerebral ischemia. High PaCO2 can cause cerebral hyperemia and can increase the ICP. So we need to maintain the normal ventilation. So coming to the Brain Trauma Foundation guidelines, hyperventilation is recommended as a temporizing measure for the reduction of elevated ICP. Hyperventilation should be avoided during the first 24 hours after injury. And if you are using hyperventilation, then we have to monitor the oxygen delivery. Either you have to use SgO2, or we have to use brain tissue oxygen partial pressure concentration if you are using this hyperventilation. But prolonged prophylactic hyperventilation should be avoided. PaCO2 25 millimeters of mercury is not recommended. Coming to the role of anesthetics, analgesics, and sedatives, this is important for the prophylaxis and control of the intracranial hypertension and seizures. Barbiturates have long history of being used to control the ICP, but the barbiturates are used in the later stage as a second type therapy, a third type therapy, but not initially. But the side effects you have to keep in mind: hypotension, decreased cardiac output, and then increased pulmonary shunting. And if the patient is on ventilator, we need to give good sedation and good analgesics, otherwise the ICP may go up. There is level 2B recommendation that administration of barbiturates to induce burst suppression as a prophylaxis against development of intracranial hypertension is not routinely recommended. And this is the evidence. And according to this trial, the barbiturates for the acute traumatic brain injury, there is no evidence that barbiturate therapy in patients with acute severe head injury improves the outcome. Barbiturate therapy can result in fall in blood pressure, 1 in 4 patients, that is 25%. This hypotensive effect can cause like the ICP lowering effect, and then the cerebral perfusion will be impaired. So the hypotension is dangerous when you are giving barbiturate coma. So we have to be very, very careful, and we have to go for arterial monitoring, and then we have to maintain the cerebral perfusion pressure along with the mean arterial pressures. You have to maintain the ICP. The high dose barbiturate, what is the recommendation? There is a level 2B recommendation. High dose barbiturate administration is recommended to control elevated to maximum standard medical and surgical management. So if you are using propofol, the propofol is recommended for the control of ICP. It is not recommended for the improvement in the mortality, or if you look at the 6 months outcomes, there is no improvement in the mortality. But we should be very, very careful when you are giving high dose propofol. Again, this can cause hypotension. If you look at the uses of steroids in traumatic brain injury, if you look at the theory, it is very good. These steroids can restore the vascular permeability in the brain edema. It can reduce the CSF production. It can attenuate the free radical production and all. But there is level 1 recommendation not to use steroids. But what is the evidence for it? Glucocorticoids benefit for the patients with brain tumors. We use steroids for a patient with in a patient with brain tumor whenever there is cerebral edema. We commonly use, but in traumatic brain injury, studies did not show any benefit. So we know the CRASH 1 trial, that is corticosteroid randomization after significant head injury trial, and this was designed to provide high quality evidence on the impact of steroids in traumatic brain injury. But there is a level 1 recommendation not to use steroids to improve the outcome or to reduce the ICP. But in patients with severe TBI, the high dose, we should remember, like for the tumor edema and all, we don't use high dose steroids. We use dexamethasone 4 milligrams TID, like that. But in this trial, they used high dose methylprednisolone and they did not find any benefit. Definitely, there is no role for high dose methylprednisolone in severe traumatic brain injury. Coming to prophylactic hypothermia, we have seen the prophylactic hypothermia results for neuroprotection after cardiac arrest after acute coronary syndromes. Again, the same prophylactic hypothermia, did it show any benefit in traumatic brain injury? So coming to the evidence, there is level 2B recommendation, that is early within 2.5 hours, or short term, that is 48 hours post injury. Prophylactic hypothermia is not recommended to improve the outcomes in diffuse axonal injury, diffuse injury. So what is the evidence? We have 2 trials. One is the Eurotherm trial. The other one is the Polar ICU trial. In Eurotherm trial, in patients with ICP of more than 20 millimeters of mercury after traumatic brain injury, therapeutic hypothermia plus standard care to reduce the ICP did not result in better outcomes compared to the standard care alone. So in Polar ICU trial, there is absolutely no sign in this trial that early and sustained prophylactic hypothermia can improve the neurological outcomes. So these 2 trials put hypothermia to bed. So the most discussed topic, that is the decompressive craniectomy in traumatic brain injury. So when you are not able to manage the ICP medically, then we know that we go for decompressive craniectomy. But in some centers, they don't even try the medical management. They directly go for decompressive craniectomy, that is primary decompressive craniectomy. So what is the role of primary decompressive craniectomy? What is the role of secondary decompressive craniectomy? So we know the cerebral edema can be because of primary injury, or it can be because of the secondary injury. So decompressive craniectomy will, like it relieves the elevated ICP. So if you look at the evidence for decompressive craniectomy, there is level 2A recommended. Important, you must know. Bifrontal decompressive craniectomy is not recommended to improve the outcomes as measured by the Glasgow Outcome Scale Extended score at 6 months post-injury in severe traumatic brain injury with diffuse injury without mass lesions. Again, we cannot say there is no role of decompressive craniectomy. Bifrontal decompressive craniectomy is not recommended to improve outcomes, but a large frontotemporoparital decompressive craniectomy, not less than 12 into 15 centimeters, is recommended over a small frontotemporoparital decompressive craniectomy. So your bone flap should be around 15 centimeter diameter. You cannot do a small decompressive craniectomy. If you are doing, you have to do good decompressive craniectomy. So what are the trials? What is the evidence for it? So we have two trials. We must know these two trials. So if you look at the decompressive craniectomy in stroke, we have three trials there. We have Hamlet trial, we have Destiny trial, we have Decimal trial. But in traumatic brain injury, we have two trials. Those are Rescue ICP trial versus DECRA trial. So in DECRA trial, they have taken 155 patients. And what is the threshold for doing decompressive craniectomy? If the ICP is more than 20 millimeters of mercury for 15 minutes in any 1 hour period within 72 hours of the injury, despite the first type therapies to control the ICP. So in this trial, they used ICP monitor. If it is more than 20 millimeters, then they enroll. And what type of surgical approach they went for this DECRA trial? They did bifrontotemporoparital decompressive cranectomy. And again, what is the evidence? What is the conclusion of this trial? This is classified as unfavorable. They have seen unfavorable outcomes. In Rescue ICP trial, they enrolled around 400 patients. But what is the inclusion criteria? The ICP more than 25 millimeters of mercury after 1 to 12 hours, despite your stage 1 and stage 2 therapies. In DECRA, after first type therapies, they have gone for decompressive cranectomy. But what kind of decompressive cranectomy they have done? They have not done bilateral in all the patients. They have done unilateral large frontotemporoparital decompressive cranectomy, and they found favorable outcomes in Rescue ICP trial. So the next trial, but we must remember that these two trials are secondary decompressive cranectomy. They tried medical management to control the ICP, and then later, if you are not able to control ICP, then they have gone for decompressive cranectomy. But in some centers, even in our center, some neurosurgeons, they prefer to do decompressive cranectomy without trying medical management when it is a severe traumatic brain injury. So that's called primary decompressive cranectomy. And now there are a lot of trials coming up with primary decompressive cranectomy. The one big trial which is going on in UK is Rescue ASDH trial. That is Rescue Acute Subdural Hematoma, primary decompressive cranectomy. And one more, I think, precise trial also for primary decompressive cranectomy. They are finding better outcomes with the primary decompressive cranectomy, but the Rescue ASDH trial results we are waiting for the results. The result have to be published. So what is the role of infection prophylaxis? So routinely, there's no role for infection prophylaxis, but a patient who is undergoing ICP monitoring, they will have infection rates as high as 27%. Again, it depends on what type of ICP monitor you are using, whether you are using intraventricular catheters or whether you are using parenchymal catheters. So the infection rates may differ. So if you're using ICP monitor, then we have to go for prophylactic antibiotics for the infection control. If you're using EVDs, then we have to go for prophylactic IV antibiotics. So these prophylactic IV antibiotics cannot prevent ventilator-associated pneumonia. We must remember this. And if they develop any VAP, then there will be significant mortality in these patients. So what is the role of tracheostomy? There is a level 2 evidence to say that early tracheostomy is recommended to reduce mechanical And then level 3 recommendation, antimicrobial impregnated catheters may be considered to prevent catheter-related infections during external ventricular drains. DVT prophylaxis is very, very important. The incidence is around 54% if you don't give the treatment prophylaxis, and 25% incidence we see in isolated TBI patients if you use only like sequential compression device, if you don't use pharmacological prophylaxis. There is significant risk because of and prolonged periods of immobilization, focal motor deficits, and then we have to go for both non-pharmacological and pharmacological methods. And there is a level 3 evidence that low molecular weight heparin or low dose unfractionated heparin may be used in combination with mechanical prophylaxis, increase the risk for the expansion of the, but there is a slight increase in risk for expansion of the intracranial hemorrhage when you are giving pharmacological prophylaxis with low molecular weight heparins. So coming to the seizure prophylaxis, the post-traumatic seizures are classified as early less than 7 days of injury or late the post-traumatic epilepsy is defined as recurrent seizures after 7 days following the injury. So what are the indications for giving seizure prophylaxis? When the GCS less than 10 or equal to 10, immediate seizures, or if the patient has post-traumatic amnesia lasting more than 30 minutes, that is moderate head injury, and linear depressive skull fracture, we need to give seizure prophylaxis. Penetrating head injury, subdural, epidural, or intracerebral hematomas, cortical contusions, age less than or equal to 65 years, and chronic alcoholism, these patients will have more risk for the seizures. And what is the evidence? According to Brain Trauma Foundation guidelines, level 2A recommendation, prophylactic use of phenytoin or valproate is not recommended. And there is insufficient data to say that levetiracetam is preferable over phenytoin at this point of time. But most of the centers we use levetiracetam, but there is insufficient evidence at this point of time. But a lot of centers we use, we find it effective. Levetiracetam is effective in these patients. So what are our thresholds for blood pressure, intracranial pressures, cerebral perfusion pressure monitoring, and if you have advanced cerebral monitoring machines, and then you should define the targets. Coming to the BP targets, BP like hypotension associated with high mortality and brain swelling in TBI patients. Ischemia. So because the autoregulation is not intact in these patients. So what are the recommendations? In patients with 50 to 69 years, we have to maintain systolic blood pressure of more than or equal to 100, that is 15 to 50 years, and around more than 70 years. Then we have to maintain higher blood pressures of around more than or equal to 110 millimeters of mercury in these patients to decrease the mortality and to improve the outcomes. And need to decrease the mortality and to improve the outcomes. And we have to monitor the CPP of around 60 to 70 millimeters of mercury. And then if you have any monitoring facilities, advanced monitoring, then we can depend on this advanced cerebral monitoring and CT findings when to intervene at of cerebral perfusion pressure. We have to maintain CPP of around 60 to 70 millimeters of mercury. This is the level 2B recommendation. So because as I told, there is no autoregulation, so we have to maintain the cerebral blood flow. So for that, we need to monitor the mean arterial pressures, and we need to monitor the ICP, and we have to maintain the cerebral perfusion pressure of around 60 to 70 millimeters of mercury. So we must remember airway is very, very important. Intubation GCS less than 8 or equal to 8 is mandatory, and we must avoid hypoxia, hypercapnia. Hyperventilation is avoided again, and we must avoid hypotension, and we have to replace intravascular volume and avoid hypotonic or glucose containing solutions. Use blood whenever it is required, and we have to uh, reverse the existing coagulopathy. We have to monitor the ICP whenever there is a requirement according to the patient. If the patient is more than 45 years, and then when there's a significant lesion, low GCS, and then we have to monitor ICP. We have to provide adequate sedation, analgesia, and then we have to use hyperosmolar therapy. We have to use CSF drainage if it is a severe head injury, barbiturate coma, decompressive cranictomy. All these modalities are reserved for elevated refractory ICP when you are not able to maintain with standard medical care, and DVT prophylaxis and normothermia we have to maintain. IV fluids, like we have to avoid albumin containing fluids. In the SAFE trial, they found unfavorable outcomes when they used albumin in traumatic brain injury patients. Vasopressors of choice, we use noradrenaline, but a good study is a single center randomized control trial. They used phenylephrine and they found phenylephrine, norepinephrine, and dopamine. They found phenylephrine is more effective in maintaining the mean arterial pressures and cerebral perfusion pressure. So we all know the tier 1 management, that is simple head and elevation. We can give sedation analgesia to the patient who is agitated, and then the ventricular drainage. If you are using EVD, then if you drain the CSF, then the ICP will reduce. And then we use repeated CT imaging to see whether the patient requires any hyperosmolar therapy. And coming to the type 2 management, that is hyperosmolar therapy with either mannitol or hypertonic saline. In type 3 management, we have this decompressive cranectomy, either barbiturate and propofol coma. So decompressive cranectomy, again, we must remember, this is not bifrontal decompressive cranectomy. A large frontotemporoparatal decompressive cranectomy is recommended, which we do in all the centers in India. So thank you so much, and I will be very happy to answer some questions. Lot of people participated, more than 100 people, 115 people participated. So any questions you can put in the chat box.
Thanks, Dr. Subbareddy, for that comprehensive coverage on ICU management on traumatic brain injury. You pretty well covered most of the important points in managing a TBI patient. To all the people who are listening to the talk, I hope you got a clarity on how to manage a patient in the ICU with the TBI. If there are any questions, please go and either you can ask or you can type it on the chat box. We have 5 to 10 minutes for discussion. Hello, anyone have any doubts?
Sir, what kind of ICP monitor you are using, sir, there in Chennai? We have one Codman monitor, and we use that Codman monitor. And before we were using intraventricular catheters. Now we are using more intraparenchymal catheters because it is easy to put parenchymal catheter. We can do bedside in ICU. So off late, we are using more intraparenchymal catheter. If there is no much IVH, if there is intraventricular hemorrhage, then we go for intraventricular catheter so that we can drain CSF.
Here, we had the Codman catheters some 15 years back. We used in some of the patients, especially in pediatrics. But of late, we have moved more towards the EVD. Okay, so that we can use both for therapeutic and diagnostic purpose. When it is very difficult, very distorted brain, then think about Codman, because placing a EVD becomes technically very difficult when there is a completely distorted ventricles. So predominantly, we are using extraventricular drain as both diagnostic as well as therapeutic modality.
Very good.
And we continuously drain the CSF. We don't do intermittent draining. We continuously drain gravity-dependent continuous CSF drain is the modality we use here. There is no strong evidence for which one to use. But there is suggestion in the BTF guidelines that better to use a slow CSF continuous drainage and a very cheaper alternative. So we are using that. Go ahead, Sumant.
And there is one question in the chat box. Yeah, I can hear you. There's one question in the chat box. What is the hemoglobin target in traumatic brain injury? So, like if you look at the stroke and then if you look at the subarachnoid hemorrhage, we have hemoglobin targets, transfusion threshold. It's for around 8. So same thing when it comes to the traumatic brain injury. So any hemoglobin target of 8 or 8 to 10 is okay in these people. So less than 8, we must go for transfusion, or 8 is okay. The transfusion trigger will be around 8 in patients with traumatic brain injury. Any comments from you, sir?
Absolutely fine. We will accept anything around 8 unless the TBI is associated with any other polytrauma and patient is actively bleeding, then we have a different goal. But if it's an isolated TBI and patient is not bleeding actively, then 8 is a very good target. But if they are actively bleeding somewhere, then we need to have a different targets.
And I can see one more question. Any specific recommendation for patients on antiplatelets or anticoagulants? Yes, if it is a coronary artery disease patient, if the patient is on antiplatelets, we must be we have to be very, very careful because the hematoma size may increase. So we have to go for, like, we had to look at the coagulopathy, we have to monitor the coagulation parameters, and we have to start antiplatelets as early as possible. When it comes to anticoagulants, in the Brain Trauma Foundation guidelines, they recommended low molecular weight heparins, but we can use even unfractionated heparin. It is easy to reverse, and we have to start antiplatelets in these patients. If there is no increase in size of hematoma, then we must use antiplatelets in these patients, because otherwise, if they have a stent, it may get thrombosed.
Absolutely. My take on this is if you see the VTF guidelines, they'll say it is at the discretion of the clinician at last. Yes. There is
Yes.
no strong evidences, high level evidences for this when to add antiplatelets and anticoagulation after an TBI. Usually they say after 1 week to 10 days, you can start at the discretion of the clinician. Okay. So if you start, there is a small chance that the bleeding can increase. We have to closely monitor. It's a risk benefit ratio. Yes, if a patient is on a PTCA and by stopping antiplatelet is going to harm the patient more, then we have to take the calculated risk. Unfortunately, we don't have a very high level evidences. So at the bedside, the clinicians has to discuss and then take a call, risk versus benefit.
And definitely elderly patients on antiplatelets, even if the scan is normal, better to monitor these people very closely, because they may develop hematoma or they may develop subdural hematoma at later stage. So we have to be very, very careful with these patients.
Actually, I have a patient right now, post TBI, could not give anticoagulation because it had a huge contusions, multiple hematomas, intracerebral hematomas following TBI, developed a huge DVT. Then we have to put IVC filter right now. And we have carefully started small dose heparin infusion along with the filter. Okay. So these things happen. So we have to be careful. We have to daily assess, can I start anticoagulation? If the patient is already on antiplatelet, can I reintroduce? So daily we have to check, see the risk versus benefit, and then take a call.
And so there's one more question from Dr. Radhika Srinivasan. So how many days EVD can be kept, or any time frame for the EVD removal? See, as I told in my presentation, the infection risk is very high. We see the infection rates of around 30% in these patients with EVD. So we have to be very, very careful. If you are if you have a good infection control practices in your ICU, we can go up to 5 days. So, but in our unit, we don't keep more than 5 days. So we keep it for 5 days. And then after that, yeah, when it comes to the intraparenchymal catheter ICP monitoring catheters, we don't keep it more than 3 days. And the EVDs maximum 5 days. After 5 days, either we will remove the catheter or we will replace. And then there is a very good trial, that is clear IVH trial in traumatic, like intracerebral bleeds in hemorrhagic strokes. They use low dose thrombolytic agents, and then they have seen improvement in mortality, because the EVD will not get blocked, and then there will be continuous drainage, and then the outcomes are better. There's a mortality benefit in that clear IVH trial. But in traumatic brain injury, we should be very, very careful in using these thrombolytic agents. There's no evidence, and then we don't use, but 5 days is the cutoff.
So any other doubts? We have another few minutes for discussion. There is a question, Dr. Subba Reddy. If ICP monitoring is not available in your setup, how to proceed? I think they're
Yeah.
asking, is there any other way of
Yeah.
monitoring ICP non-invasive?
Yes. So if the ICP monitor, if it is not available, and even if it is available, we don't use it many a times because of the cost, and we have to depend on non-invasive ICP monitoring. We can use we can use ultrasound, and then we can use optic nerve sheath diameter, and then you can correlate ICP. And if you have, and then in some centers we use more imaging CT scans to see what is happening to these mass lesions, midline shift and all. And then if you have transcranial Doppler, we can do transcranial Doppler, and then we can look at the perfusion. Otherwise, optic nerve sheath nerve diameter measuring ONSD will give you we can see the trend, how the ICP is changing. But definitely you cannot do it. Is not a continuous monitor. See, sometimes like when you have ICP monitor, you can see this more than ICP more than 20 millimeters of mercury for 15 minutes, 20 minutes. So when the patient is getting agitated and all. So ONSD we cannot monitor continuously. So during night times and all, how is the ICP trend and all, we cannot monitor. And then that's why we depend on the more neurological monitoring, pupillary monitoring, and the GCS monitoring in these patients.
How frequently you do ONSD, Dr. Subbareddy, in a patient with a severe TBI, if a EVD is not there or ICP monitoring is not there? Do you have a protocol? You do once in 8 hours something and document the ONSD size?
Once in 8 hours, and the problem is the night time. Sometimes the night times when they're busy, so they're not able to do. But generally, when during daytime when more residents are there, we do once in 8 hours, and then we monitor, we document it. It depends on the case. Sometimes we do more frequently also in these in a sicker patient. So
One practical
one more.
point I want to ask from intensive standpoint, if there are more doubts, what anti-edema measure you practically use and how you use?
So we use I have not used mannitol in recent times. We completely switched over to hypertonic saline, but they say the best is to give 30 ml saline bullet of around 23%, which is not available in our country. So before we were using 3% saline as infusion, either 50 ml per hour like that, but we did not find much benefit. When you're looking at the serum sodium levels, they're not increasing. Sometimes you increase the infusion and then you continue for one day, the sodium levels are not going up. And in the operating room, when they're doing surgery, they use a bolus of around 100 ml or 200 ml 3% saline. The same thing we are practicing in our unit, neurocritical care unit. And then we are finding better results when you give boluses of 3% saline as 200 ml or 250 ml boluses.
Good. This is what we do is we always start with boluses and continue infusion. And if the sodium rise is not going as per our wish, we keep bolusing in between. And do you combine mannitol sometimes if the patient clinically is deteriorating on 3% saline?
Like we have not used mannitol because we have a neurosurgery team. They are all from CMC Vellore, and they prefer mostly 3%.
Only 3% saline.
Only
Okay.
3%
Yeah.
saline.
Sometimes
So
the rescue, we give a on 3% saline, we have bolus 3% saline. Still patient ICP is going up or not improving. Sometimes we combine mannitol also. That's why I ask these questions. Do you guys use those things? And coming to AED, you regularly use levetiracetam. Yes, that has become a standard of care now.
Yes, that is a
levetiracetam. How long you use?
So
as a prophylaxis?
Yeah, as a prophylaxis, we are using it for more than 1 month. The problem of using AEDs are like, if you are in a foreign country, you cannot drive your vehicle if you are on anti-epileptics. So your driving license will be cancelled immediately. But in our country, I don't know that people, they don't follow these regulations that properly. And I have seen in our we strictly try to stop these anti-epileptics after 1 week. and if there is no evidence of seizures, because there's no use of prolonging these anti-epileptics. They don't prevent long-term epilepsy, and they cause more cognitive impairment in these patients. So we don't prolong it more than 1 week.
1 week, okay. We also prefer
There is
levetiracetam because there are a couple of studies, especially observational studies, have come in BMJ about using levetiracetam. They are either equipotent or slightly the side effect profile is slightly less compared to phenytoin. So we can, I think, boldly use levetiracetam now in prevention of post-trauma seizures. Okay, there are a couple of questions. We will take that and then go to the next talk. Any recommended antihypertensives in TBI?
Yes.
I think in a TBI patient with hypertension, is there any recommendation on the drug of choice?
Initially, in any other neurocritical care patient, the drug of choice is injection levetolol because it is short-acting tension. So if you give any oral agent, it may cause hypotension. It can worsen secondary brain damage. So we have to go for short-acting IV. We can use levetolol, but many a times we see traumatic brain injury patients will have bradycardia. So when you are using levetolol, we see more bradycardia. So we have to be careful if the patient has bradycardia. But if the patient is on ventilator, we can use dexmedetomidine, we can use propofol, and then we can slightly bring down the blood pressure instead of giving long-acting oral agents. And the BP thresholds, I already told, it is systolic BP more than or equal to.
Mic check.
We have to maintain.
Okay, thank you, Dr. Subba Reddy. That was a nice discussion. I think it's time to move to the next topic. Thanks again. I now welcome the second speaker of the day, Ms. Ravita Bajwa. Okay, Ms. Ravita Bajwa is going to talk on the nursing issues in TBI, and her background is from nursing background. She has close to 5 years of experience in nursing, and she has a special interest in trauma, and she wants to focus on managing trauma patients based on ATLS guidelines. That is our aim in life. I welcome Ms. Ravita Bajwa for the second talk of the day. Welcome, Ms. Ravita. Go ahead. It's all yours. Next 30 minutes.
Namaste all. Good afternoon. My name is Ravita Bajwa. I am working as a registered nurse in the ICU in Apollo Hospital, Navi Mumbai. I would like to thank Dr. Usha Banerjee ma'am for giving me this opportunity to be presenting in front of you all, and also under the guidance of Dr. Sneha Vaidya, who is the nursing HOD of Apollo Hospital, Navi Mumbai, Dr. Tushar Parmar, who is the senior intensivist in Apollo Hospital, Navi Mumbai, and Dr. Nitin Jagasia, who is the HOD of emergency. So like rightly said, I would like to move on with just following up to what Dr. K. Subba Reddy had already been explaining throughout this last 1 hour that we all have been hearing. I would like to say brain injury is a puzzle. All the pieces are there. But not in a proper state. So it's not easy because brain injury cannot always be seen from a naked eye. So I would just be taking you all further with the nursing management of head injury. So nursing management and continuation of nursing care. Initially, we start off with the GCS monitoring of the patient, along with the collaborative antibiotics and everything. And the doctors would be doing the GCS management, but also being a nurse, it is a very important role for us also, because us being there with the patient for a longer time than the doctors would be, we also need to understand what is GCS and how do we monitor it. So as you all can see on the screen, there are mainly 3 components of GCS monitoring. One is the eye-opening response, which has 4 scoring. Initially, the spontaneous eye-opening is scored as 4, 3 to speech, 2 to pain, 1 to no response. It equals to E4. Then moving on to the next component, that is verbal response. Its score at the highest of 5, which is oriented to time, person, and place. 4 is confused. 3, inappropriate words. 2, incomprehensible sounds, which is, some sounds would be present, like as if gurgling sounds are present or something that cannot be identified. You can, you can give it a score of 2. And 1 is again no response. Moving on to the third component, that is the motor response. 6 is obeys commands. 5 is moves to localize pain. 4 is flex to withdraw from pain. Third is abnormal flexion. Second is abnormal extension. And 1 is no response. So we would score it as E4, V5, M6. That is, the total is 15. And then we would expect a normal person's GCS to be somewhere around 15 by 15. Now, in patients who come to us in a state of a traumatic brain injury, we would be wanting to evaluate the patient's, reevaluate the patient's GCS time to time, so that we can understand if the patient is having any increase in the ICP levels, or if the patient's not maintaining his certain vital parameters. So moving on to the next slide, how do we recognize that the patient is going into a phase of stroke, or is going into like, for us to understand how do we understand stroke? So we use this term as FAST. F is for face drooping, as you can see in the picture on the slide. A is for arm weakness. S is for speech difficulties, and T is time for call. Now, how do you see, and what is intracranial pressure? So the intracranial skull contains 3 components, main, that is brain, blood, and cerebrospinal fluid. So the rigid cranial wall contains brain tissue, which is 1400 grams, blood, which is around 75 ml, and CSF, that is cerebrospinal fluid, which is around again 75 ml. The main volume and pressure of these 3 components are usually in a state of an equilibrium and produce the ICP. So ICP, as it says up there, it is intracranial pressure. ICP is usually measured in the lateral ventricles. Normal ICP is around 15 to 20 mm of Hg. Now, how would we as nurses understand that there is, signs which are signs where the intracranial pressure has increased? So there are something called as early and late signs. So the early signs would be slowing of the speech, delay in responding to questions, restlessness and confusion, pupillary changes, weakness in one extremity, headache, constant, and it would aggravate by movement, increase in intensity. Moving on to the late signs, which is LOC, deterioration or deteriorates to comatose state, bradycardia or fluctuating heart rate to tachycardia. Third is decreased respiratory rate. Fourth is altered respiratory pattern, like chain stroke of respiration. Fifth is BP and temperature rises. And sixth is widening pulse differences between systolic and diastolic pressure. So like Dr. Subhakir Reddy had correctly said that you had to maintain this SBP in the certain, he's given a very nice presentation in where he mentioned the age group and the SBP that you would have to maintain. And projectile vomiting. All these are, and decorticate of decerebrate posturing followed by bilateral flaccidity. So this basically means that the nurses are there and they are supposed to know these signs so they can immediately identify any deterioration in the patient. Loss of brainstem reflexes. Again, your pupil, corneal, gag, swallowing are continuous signs which will be indicating that there is a loss of brainstem reflexes, which the nurses are supposed to be aware of. Then how do we do maintenance of ICP? Maintenance of ICP is management of increased ICP should include sedation, drainage of CSF, and osmotherapy with either mannitol or hypotonic saline. For intracranial hypertension refractory to initial medical management, barbiturate, hypothermia, or decompressive craniotomy should be considered. As again, I don't need to go into details of this since Dr. Subhakir Reddy has nicely explained it. Again, the normal ICP is mentioned over here. It's 5 to 15 mm Hg or anything less than 20 mm Hg. Now again, maintenance of MAP. Following up to what Sir had already said, the definition of mean MAP or mean arterial pressure is the average of arterial pressure throughout one cardiac cycle, systole and diastole. MAP is influenced by cardiac output and systemic vascular resistance, each of which is influenced by several variables. A common method used to estimate the MAP is in the following formula. So its MAP is equal to diastolic pressure plus 1/3 of systolic pressure minus diastolic pressure, or MAP is equal to diastolic pressure plus 1/3 of perfusion pressure, where DP is the diastolic pressure, SP is the systolic blood pressure, PP is the pulse pressure, and the method is most common, more often conductive to measuring MAP is most clinically settings as offers as quick means of calculation in the blood pressure is known. Moving on to the nursing care plan. Nursing diagnosis of a patient with TBI, decreased intracranial adaptive capacity. This all can be related to injury with cerebral edema, intracranial hemorrhage, increased cerebral blood flow. All this is evidenced by increase in the cranial pressure more than 10 mmHg, elevated ICP waveform, baseline ICP greater than 10 mmHg, and the expected outcomes would be patient maintains optimal cerebral tissue perfusion, ICP less than 10 mm of Hg. Risk for electrolyte imbalance, excess fluid volume, the compromised regulatory mechanism with increase in antidiuretic hormone, evidenced by decrease in urine specific gravity, presence of edema in the sternum, expected outcome decrease in weight to normal, increase in output to 30 ml per hour, urine specific gravity is 1.010 to 1.030, BP within baseline limit. Risk for seizures related to, again, cortical lacerations, intracranial bleeding, hyponatremia, hypoxia, penetrating injury to brain. Expected outcomes would be the patient does not sustain injury due to seizure activity. The patient does not experience any seizure activity. Risk for imbalanced nutrition less than body requirement, related to facial trauma, restriction of intake, impaired level of consciousness. So to check the impaired level of consciousness, the nurses need to know how to monitor GCS of a patient, and multi-system trauma. Moving on, if at all, despite all your major management, be it medical, be it surgical, sometimes what happens is the patient is not able to reach to where, to the place of survival. So what we do is we start counseling the family for organ donation. So how would we do that? The family needs to be given information in detail about organ donation, and further counseling needs to be done for them to decide on the same. Then there is something called as apnea test that can be conducted. So I would just go in a little detail to explain to you all what is apnea test. Apnea test is the most important clinical test performed usually at the end of brain death diagnosis procedure. Traditional inflation of apnea test cannot be completed in patients with extremely compromised lung function due to rapid desaturation and circulatory disturbance. So there are two tests which are done. If the first test is positive, only then we can proceed to the second test. The family counseling needs to be done, and consent signatures needs to be taken by the authorized clinicians and the supportive transplant coordinators. And if they agree to donate the patient's vital organs, then only we can, after all the formal documentation is done, the patient will be then shifted to operation theater, and all the above mentioned organs will be retrieved, and the patient will be declared dead after that. Now, being a nurse, apart from what all has been explained, I would also like to mention the patient's skin integrity is something which is very important. Changing of positions and following the DVT prophylaxis is something which is very mandatory. Like, you know, even if it might not be written in books, but it's something that a nurse needs to do. Apart from the pharmacological management of prevention of DVT, we can use something as sequential compression devices for our patients to make sure that the patients who are immobile or are in bed for longer than what we would expect them to be, and the outcome is poor. We need to make sure that we do something from our sides. Being a nurse, we can use or encourage the patient to maybe be and do exercises when they're in bed. So on that note, I would like to sum up by saying we don't know how strong we are until being strong is the only choice that we would have.
By the way, excellent presentation, Ms. Ravita. Thank you so much.
Thank you, sir.
I think a lot of nurses also attended. So nurses' role is very, very important. And both of us, we did not cover much about rehabilitation, which is very, very important in either stroke or traumatic brain injury patients, and early comes and swallow test, when to do swallow test, when to feed the patient, what kind of nutrition we have to give. These things are very, very important for better outcomes in a patient with a traumatic brain injury.
Yeah.
Sorry, Subbaradi. I was
Yes,
on the call.
Yeah.
Okay,
No problem.
Anyway. Hello, any doubts? Please put in your chat box, please. Hello. Okay, anyway. Ms. Bajwa, thanks. Thank you very much for even covering the organ donation aspect also. Okay. I have a query. As a nurse, what do you think is the most challenging part in managing a TBI patient?
It's if you say in terms of patient care, we tend to forget about the non-pharmacological part instead of like there are only a certain amount of people who would be stressing on this. Apart from the medications, there is something called as the physical or the procedures that we might have to do and we should be doing for the patient. In terms of the basic things, you know, just giving position to the patient to make sure that there are no pressure ulcers that the patient would be developing at the stage when they are in the hospital, or also in terms of making sure that the patient is when the patient's suppose intubated or on a ventilator, so making sure that the patient does not develop WAB or COTI or CLEPSY when they're in the hospital. And to basically we need to make sure that we should prevent long stay of the patient when they are under our care.
Thank you very much. That's the most important reason I asked this question. Every nurse here should understand that neurological patients have the highest ICU related complications. Okay, whether it is infectious complication or non-infectious complication, it's the neuro ICU patients have the highest. So a lot of these interventions, either pharmacological or non-pharmacological interventions, has to be monitored by the nurse, especially the non-pharmacological intervention, as you mentioned, the positioning of the head, back elevation, if the patient is an intubated, the WAP bundle, the complaints of the bundle therapies, yes, using the SCD, proper back cares, all those things are very, very important in neuro ICU rather than any other ICU, because neuro ICU patients or low conscious patients have the highest ICU treatment related complications or therapy related complications, either infectious or non-infectious. The benchmark is higher. So it is in the nurse's hand to prevent that. Okay, so the role of nurses, as Dr. Reddy mentioned in the beginning, they have a huge role here in the whole ICU, but more so in a neuro ICU. Neuro patients, they have a huge role to play. So everyone should make sure that you all get rotated in a neuro ICU, get exposed to all these things. How to maintain the bundles, how to make sure head of the bed is elevated properly, back care, SC, DVT preventions, everything is in their hand. Oral care, because most of these patients would have extubated, they are on a borderline GCS, giving proper oral care, looking for micro aspirations. All those things are very, very important. As I just now went to see a patient, I'll tell you another complication in a TBI patient. We have done a decompression craniotomy yesterday night as an emergency, has been extubated today morning. He pulled out the Ryle's tube. Okay. So that's another complications. The neuro patients are restless. They pull out the tubes. Okay. Not only that, they replace the Ryle's tube, and unfortunately it has gone into the left lung and it has been fed. Okay. So these are complications are very high in neuro ICU patients. Okay. So be careful that, okay, to look at these things. These are all, most of these things are in nurses' hands because they are at the bedside looking at these things closely. Okay, if you are monitoring the patient closely and following the checklist, these complications can be prevented, avoided. Okay, thank you. Any other questions? Okay, there are some questions. Why should we check MAP for all the stable patients also?
Checking the map. So basically, again, checking the map is important thing, since we are eventually wanting to reach to check that we need to make sure that the ICP level is in the normal range or within the normal limits, because the moment you check map, you need to minus the map from the ICP to reach to the perfusion pressure of the patient, of the brain. So checking the map for all the stable patients is also an important component, because to know that the patient is neurologically stable, and to make sure that the cerebral perfusion is at the proper state, we need to make sure that we check MAP for all stable patients as well, because you never know when a patient will be getting deteriorated.
Thank you. See, we check MAP in all the ICU patients because MAP is a marker of overall perfusion status. Okay, so it's not systole, it is not diastole, it is the MAP, mean arterial pressure, is a marker of overall perfusion. So we take MAP as a surrogate marker, especially in TBA patient, when we do not know exactly what is the ICP. In all moderate to severe TBA patient, we consider their ICP as more than around 20, and we try to keep a MAP 20 centimeter more than the normal. Okay, 20 millimeter more than the normal, 20 millimeters of mercury more than the normal, which is around 60. Yes, 60 MAP is what usually we accept in TBA patient with moderate to severe injury. We consider them as a ICP more than 20 because many times we don't measure the ICP. We consider ICP is more than 20. So we try to keep a MAP 20 millimeters more than the normal MAP 60. And so we maintain a MAP of around 80. That's what usually as an intensivist is, right? In a tight brain situation, we maintain a MAP around 80 in all TBA patients with moderate to severe head injury. That's why MAP is important. Any other doubts? Anything else?
I think there's one more doctor in the chat box. Ms. Muthuram has asked what precautions need to be taken care while shifting the TBI patient for investigations like
what precautions need to be taken care while shifting the TBI patients for investigation like CT. Okay, if but the consciousness is very important, their ABC to be taken care of. That's one thing very not uncommonly missed, you know. A head injury patient comes, you all rush up to do a CT without securing the ABC, which is not required at all. In any trauma patient, the sequence is ABCD. So you look at A, if there is a problem, fix it. If there is an B problem, there's a breathing problem, fix it by intubating, ventilating them properly. If there is a C circulation problem, correct the BP. If there is bleeding, correct the bleeding, stop the bleeding, all those things. Then look at the CT brain. Okay, so what is happening practically commonly is people rush in a TBI patient or a suspected TBI patient. They rush to do a CT without securing the airway, breathing, circulation. Then we land up in problem in the CT room. Suddenly, patient arresting the emergency lines are inserted, tube is inserted, all these things. Okay, so when you shift a patient, make sure the ABC is all right. The second point, if the patient is going from the ICU, already intubated and everything, going to the CT scan for imaging, make sure they are sedated properly, they are restrained properly, either chemically or physically. Because as I told you earlier, TBI patient can be restless, they can pull out the tubes. So make sure that they all chemically or physically restrained before shifting, and make sure the tubes are in position. Okay, so they can be dislodged while shifting. So make sure these things are done before shifting the patient for safety. CT. Anything else? Anything Dr. Reddy want to add? Dr. Subbareddy, you're online.
Mute me. So nothing from my side.
Okay.
Nothing.
Ms. Bajwa, anything you want to add for the nursing side?
No, sir, that's it. I think I've covered most of it.
You can share your practical experience when you faced a difficult TBI patient, any challenges you faced, how do you face those challenges?
So we had a case here in Apollo, Navi Mumbai, wherein there was a 23-year-old male who had encountered a car accident, and he was brought to the emergency. And immediate evaluation was done by the doctors. And therein, they had decided to intubate him, and then eventually he was shifted to the scan, and the scan had showed SDH and SAH as well. So then, again, whatever we discussed throughout the presentation today, like in terms of what Dr. Subaki Reddy said, and even whatever I had explained in terms of the nursing management is something which plays a vital role. Like we had missed out on the transportation of the patient, but somebody brought it up. Transportation of the patient needs to be like, we need to make sure even if the GCs is not following down, we should make sure that we are always ready for, to encounter any sort of emergency situation that might come up. Like you said, sir, ABC, securing ABC is very important. I remember transferring that patient from the ICU to the CT scan, even though my airway was secured. But we were trying for the, the WAP bundle says sedation and vacation, and we were on that phase, and sedation and vacation was not possible. Then we were moving down for the post the CT scan, we moved on for an EEG examination, which was an and that all these things is supposed to are some things that we as nurses are supposed to understand, that when a patient reaches in such a stage, we know that it could be the next thing that the neurosurgeons or the team of the ICU would be doing is declaration of death of the patient, or a brain death for a patient. So family counseling is very important here. It's not just a doctor's job, but also supporting the family is something that a nurse needs to be actively participating in, which I have noticed that most of us nurses would want to run away or escape from that situation. So being a part of the counseling, so being there till the end of the journey, either to the disposal of the patient to the wards, or to the OT for retrieval of the organs, is something that nurses should be actively participating in.
Good. Okay, there is another question that has been raised: how to prevent the burnout and build resilience among neuro nurses to handle such patients? Ms. Bajwa, do you have any idea on this?
I would
how
say
to
more
prevent burnout.
I would say more practice for the them to go and clinically experience, and like you correctly said, for posting each and every nurse to the neuro ICU so that a complete exposure can be given to them, so that they can actually be and practically, like be there in those situations.
Okay, how to prevent the burnout if they are in the neuro ICU for long? I'm sure that even in general ICU, the nurses are posted for a really long time. They are all stressed out. Their stress levels are high. They can burn out. More so in a neuro ICU because they see a lot of patients with persistent vegetative state. Yes, a lot of patients, brain dead patients, more than other ICUs. Generally itself, ICU care, ICU nursing is stressful. More so in a neuro ICU because of these things. Okay, persistent vegetative state, brain dead patients. Yes, a lot of young guys. Okay, in general ICU we see a lot of elderly people, geriatric population. That's at least we accept the death there. These are all young breadwinners. Yes, so the stress level is so high. The relatives are so tense. The nurses are facing them directly. So they are all under a lot of stress because of these reasons. Okay, so the question is, how can we handle this? How can we make our sisters strong to prevent this burnout, to build the resilience in them?
I would say arranging for counseling for these nurses could be one way to prevent, prevention of burnout. So that can be done by the intensivists who are present there, or even the fellow nurses, or rotation of duties. These are the only two things that I feel that could help.
Okay. You're talking to them, yes?
Yes. But
Gordon?
Sorry, if you permit me to talk, I can highlight a bit.
Yeah, please go ahead. Please go ahead.
Yeah, this is Muthuram from Apollo Cancer Center. I know it is a real stressful situation for the nurses who work in the neuro unit, because most of the patients are restless with the restraints on them, and another side, the patient's relative with the high anxiety level. So it is better, like we can have a crash course training done with the neuro and the general ICU, so that the nurses can be put on rotation wise, so everybody is equally able to take participation in that. And also we can give a little bit of relaxation in between, but which is not currently possible considering the attrition level and the occupied workload of the nurses. So the best way is we can have a rotation wise cross-trained nurses in the common ICU and the neuro ICU. We can rotate them. We can take them a month somewhere outing, or some refreshment, or some get together. We can have it for them. Also, we can enhance some stress relief measures like yoga. This all things we can teach them. That would be helpful for them.
Exactly. I think as Ms. Bajwa mentioned, counseling them is very important to build their inner strength. Is very important. Then identifying these nurses, taking extra care who are under stress is also important. Generally, as you mentioned, see, rotation, I think, is practically a challenge, because most of our units are, there is no separate neuro ICU. There's a general ICU where neuro patients are also there. So these nurses, always they are seeing neuro patients and then general patients like that. If they are specifically in neuro ICU alone, rotating them to general ICU becomes a challenge practically. I see there is a point there, but then how practically we can achieve that is a problem, because always we are running short of nurses, and rotating these nurses who are trained in neuro critical care to a general care becomes a challenge. So what is practically out is building their inner strength and giving them a break. Having some sort of relaxing time, yogas, all those things are practically possible. Than rotating, I don't think so will be possible in our setup at this point of time. When we have adequate nurses, then we can rotate them. Till that point, I think building their inner strength and giving them a break and yogas and other ways of breaking their stress will be more practically possible. And of course, as you mentioned, train the nurses under neurocritical care, regular teaching, and have a module, have neuro intensive care module for nurses and keep training them. See, when they have the confidence, they can face it and their stress level goes down. Even then, they can get stressed because of the type of patients they are seeing, and the expectancy from the family and the physicians are high. So they are put under stress. But if they have the confidence with the knowledge, they can face it to a certain extent. And of course, combining with the other things we mentioned earlier, I think the burnout can be brought down. Thanks, Ms. Muthra.
So I would like to mention something.
Yeah, please go ahead.
Yeah, I'm Dr. Sneha Vaidya, the nursing director for Apollo Navi Mumbai. So talking about the burnout, what we do over here is, yes, it definitely happens everywhere. Nothing very special about it, but what happens is the ICU in charge who are there, they identify these burned out, phases of the nurses that are there that are constantly facing these kind of issues. So these pops out in the form of stress or maybe inability to concentrate or whatsoever. So these names are sent to the nurse educators who are there, and then we put them to the psychologists whom we have in the hospital. So they undergo stress level managements, which are free of its kind in our hospital. At the same time, we also believe that we build another kind of a team. There would be another kind of a team who would show an interest to work in the neuro ICU. So that sums it up, and slowly one of its kind we would allow. Not that probably sometimes we did try to see if a rotation could help. To an extent it helped, but to some extent we couldn't. And these are the challenges. And I've most of the time seen the intensivist, throwing out a little party in the ICU itself, or maybe, chatting with them off the duty hours with a cup of coffee or with something like that. So that really brings out burnout issues are sorted out, or like we meet them and then that gets sorted out. So something of that sort we try and plan out. So.
Good.
Dr. Senthil, sorry,
Go
Dr. Senthil, I would also like to step in here. That question was posed by me.
Oh, yeah.
I'm Usha Banerjee.
Okay.
Thank you so much.
Welcome for your inputs. Please go ahead.
Yes. I think Ravita and you have actually covered the question that I asked. And I brought this point up because we see a lot of this burnout happening today in most of our nurses, and especially those, like you said, in the critical care, and much so in the neuro space, because they deal with patients with cognitive impairment, difficult sensory processing. They have patients have communication issues. There are multiple seizures that they deal with. And they see a lot of other stuff around the vegetative state that you spoke about, et cetera, et cetera. And I think building resilience is a very, very important topic. And you've already mentioned that. For that, I think the nurses themselves have to learn to manage to go through various programs that are available in the world today, where it talks about building resilience, and nurses have to really spare time and get in there. While they do that, I think as an organization, we should be sensitive to the emotional well-being of the caregivers, and largely the nurses, because they are the front end and the front line of the care process. And what's important for me, I feel it is time for us to break this red tapeism, hierarchy, and the unlimited scope of expectation that the nurses undergo. There has to be role clarity in what they do, what they deliver. And I think we must create a no blame, no shame, no name kind of a culture whenever things happen. We should look at more of a system process improvement rather than an individual to be penalized for whatever happens. Number 3, and largely I bring this to the table, every neuro patient's success is teamwork. It cannot be one individual. It cannot be one person. So rewards have to be shared equally in public. People must bring to the surface the good work that nurses have done. And I think too long it was not done. So as a head of nursing, I request all our consultants who deal with complex patients and when they go home to ensure that they remember the nurses who have dealt with their patients, both in the families and in public. So that's my take, Doctor.
Absolutely. I agree with you, Shusha, that not only complex patient, any patient in the hospital is not individually managed. It is managed by a team. Yes, whether it is a OP patient or IP patient or ICU patient, uh, teamwork is the bottom line. Yes, so we need to share whatever good or bad. It's just that to be shared between all the team members. So that should be kept in the mind. And I always tell in my ICU, more so ICU is driven by nurses. You see, hospital OP can be driven by doctor and nurse assist, whereas it is reverse in an ICU because the 1:1 care is given by the nurses. Unless they pick up, they come and tell the doctors. Doctors cannot go and do something to the patient. Okay, so the 24/7 care is delivered by the nurses in ICU, and ICUs are usually nurses driven. Predominantly, the role of nurse, especially in critical care, is much more than a OP or a IP. So there is no question about that. Teamwork is the bottom line. And as you told, good or bad, everything should be shared among the team members who took care of those patients. Okay, so definitely. The second point, well said, that we need to elevate them, first of all. Okay, give them the responsibility and the power. Okay, so all those things, empower them, all those things. Many times I think these two junior nurses, they are not empowered adequately. To empower them, the first step is adequate knowledge. Yes, then we need to give cognitive skills, we need to train them appropriately in psychomotor skills, then empower them, give the knowledge, then empower them, then give the psychological support as well, because that culture in India has to be broken and they need to be empowered adequately. Then the combination of good knowledge and good empowerment, I think that will help them to work with confidence, and that itself will bring down the stress levels. Yes, that itself give them the resilience. I know what I am doing and I am empowered to do that. Okay, that give them this mental strength. Their empowerment gives that mental strength and that resilience. They can handle the situations better. So I think it's well taken. It has to be done, as you told. It has to come from bottom down and from all directions, yes, to help them to achieve this level. Thanks for your input. Okay, I think we have discussed adequately, and thanks everyone for sharing their views. Thanks everyone for asking the doubts, and a big thanks to the speakers, Dr. Subba Reddy and Ms. Bajwa, for those wonderful complete coverage of TBI from our intensivist angle and from the nurses angle. And these things are recorded and it can be further shown to other people. I think we can talk to the management guys whether these videos can be shared. Okay, so that also the nursing department can make use of that. Thanks to all the participants. Thanks to Jude for holding on to this. Thanks everyone.
Thank you, Doctor.
Thank you.
Thank you, Dr. Sendil, for excellently moderating the session. Thank you so much.